Good afternoon, everyone. Thank you so much for joining us for our webinar on implementing strategies to reduce overdose fatalities. We're really excited to have a great set of panelists and speakers today and really dig in to learn more about the opioid overdose reduction continuum of care approach and showcase a lot of the important work coming out of the Healing Community Study. My name is Jessica Halsey with the Addiction Policy Forum, and really grateful to you all for joining us today. APF is part of the HEAL Connection Center to help translate science and new knowledge coming out of the HEAL initiative, and we're really excited to be able to share content on the ORCCA and healing communities as a part of that work. We have a great lineup today. Just do really quick introductions of our great speakers. We have Dr. Radonna Chandler, the director of the Healing Community Study at NIDA, Dr. Alex Wally, professor of medicine at Boston University School of Medicine, Dr. John Winhusen from the University of Cincinnati College of Medicine, Dr. Tim Hunt at Columbia School of Social Work, Social Intervention Group, and Dr. Trish Freeman from the University of Kentucky College of Pharmacy. I'm really excited about the content and the framework that we have to share with you today. At the end, we'll also go over resources and other content and materials that we have available to share the ORCCA framework with your own communities and organizations. So we'll get to that later. And now I will hand it over to Dr. Chandler.
Thank you, Jess. It's a real pleasure for me to be here today with this great panel of individuals that have worked so hard over the last 4 years to talk a little bit about the Healing Community Study and to dive into the ORCCA specifically. So I'm going to provide an introduction to the Healing Community Study. I'm going to talk a little bit about requirements for EBP inclusion in ORCCA and implementation, and then just to introduce you. Then we're going to hand it over to our panelists who are going to do a deep dive into the 3 menus that are present on the ORCCA, and then we'll have a question and answer session. So for those of you who are unfamiliar, the Healing Community Study was launched in 2019 with a very ambitious goal of trying to reduce opioid overdose fatalities by 40%. We developed an intervention called the Communities That Heal intervention, and we tested that on opioid overdose deaths and associated outcomes within 67 highly impacted communities in the states of Kentucky, Massachusetts, New York, and Ohio. We also wanted to determine the cost and the cost effectiveness of CTH. And the Healing Community Study is a very scientifically rigorous study in that communities were randomly assigned to either participate in the intervention or be waitlist control communities. And we collected outcome measures during a period of time, and we compared those outcomes between Wave 1 intervention communities and Wave 2 waitlist control communities. So here are maps of our 4 states, and you can see the communities that participated in the study, including those in orange, who participated in Wave 1, and those in dark purple, who were Wave 2 communities. At the end of December, we concluded our intervention in our Wave 2 communities, so we're actually done now with the intervention phase in both sets of communities. And I'm not going to go through all of the statistics on this particular slide, but it does show you some of the characteristics of the communities that were selected, including the really high opioid overdose death rates at baseline within all of those communities. The number of rural and urban, we know that solutions in urban communities often may not work in rural communities and vice versa. So there was a real commitment to having representation from both rural and urban communities. And in terms of population, the HCS impacted over 10 million individuals. So the intervention itself was composed of 3 components, and we're going to dive deeply into one of those 3. There was a community engagement process that worked with communities to develop coalitions and go through a set of stages in order to develop a data-driven response strategy. And that from that response strategy, they selected evidence-based practices that were a part of the opioid overdose reduction continuum of care approach, or the ORCCA, and that's what you're going to hear about today. And then we did a set of communications campaigns that were designed to be able to reduce stigma as well as drive demand for evidence-based practices. So the ORCCA is a menu of evidence-based practices with clear evidence that supports the ability to reduce overdose death. And you'll hear about and see at the end of each presentation a set of resources with regard to the evidence behind each of those. The 3 strategies focused on overdose education and naloxone distribution, or OEND, enhancing the delivery of medications for opioid use disorder, which included both initiating new people on medications as well as retaining people on medications for opioid use disorder, and improving prescription opioid safety, and then also safe disposal. And the ORCCA includes technical assistance guides as well as training from outside and within the study. So there are 19 strategies that are outlined within the document that is being that has been developed and is being disseminated through Heal Connections. And through those, you will see some of the overall ORCCA strategies, as well as those within the 3 menus. You're going to hear a lot about the 3 menus, so I'm just going to briefly introduce you to the overall ORCCA strategies. One is to prioritize the delivery of services to those who need them the most in criminal legal settings and other high-risk venues like syringe service programs. The second is to implement field-based population detection methods so that you can understand and know who is overdosing and the locations of those and be able to respond quickly. The third is using data sources to target interventions to those who need those services the most. And we pulled together a lot of different data streams for the Healing Community Study and have information available on the different types of data streams that communities could consider. And then the third is to engage those with lived and living experience in decision making and within the entire process. And you'll hear more about the strategies under the 3 menus from our presenters. So this just shows from a conceptual perspective that the ORCCA really went from looking at secondary prevention and primary prevention, from primarily trying to prevent an overdose and prevent an overdose fatality, all the way through sustained recovery. And that you can see how the different menus map onto that full continuum. The ORCCA does not include anything on primary prevention interventions like school-based prevention as an example. That's not because we don't think that's important, we do, but it's just that within the Healing Community Study, the time frame of the study and the need to show reduction in overdose fatalities in 3 years, we didn't have enough time to be able to look at the long-term benefits of things like primary school-based prevention. So what I can say is that we were successful beyond our wildest dreams in helping communities in Wave 1 and Wave 2 select evidence-based practices from the ORCCA and implement those evidence-based practices. You can see that communities implemented over 1,000 of the practices you're going to hear about today, which really demonstrates the utility of the process as well as the strategies that you'll hear about. 439 around OEND, 393 around MOUD, and 203 from safer prescribing. So now I'm going to turn it over to my colleague, Dr. Alex Wally, who's going to talk about Menu 1 and OEND.
Thank you, Radana. Hi, everyone. My name's Alex Wally. I'm a general internist and addiction specialist at the Boston University School of Medicine and Boston Medical Center. I also work with the State Health Department on substance use and overdose. And it's a real privilege to be here today, especially because as I reflect back on the last 5 years, the work we've done in communities, which Tim Hunt, I think, is going to talk about, and also just the work with the colleagues across the 4 states has really been very rewarding and enlightening. So I'm going to focus on naloxone and overdose prevention education. Naloxone is a medication that can be given as a nasal spray or injected into the muscle, under the skin, or into the veins. Naloxone administration reverses an overdose if administered in time. And time is a very important factor with naloxone administration, especially in the setting of fentanyl. It used to be that we had minutes to hours to administer naloxone, and it could still be in time after somebody used an opioid like heroin or oxycodone. But with fentanyl, we really need to administer naloxone within seconds to minutes after they take the drug that's causing the overdose, if it's fentanyl. And so it's really important to have naloxone at the scene of an overdose and for it to be administered as soon as that overdose starts. Very importantly, after, still during wave 2, but effectively really on the shelves at the end of the study this fall, announced March 29th, but really in stores in September, October, November, the U.S. Food and Drug Administration approved Narcan for over-the-counter non-prescription use. There is also another formulation that's now approved for over-the-counter. So naloxone is now available over-the-counter in your retail pharmacy and other places. So the intervention isn't just naloxone, it's also overdose prevention education, which is coupled with naloxone distribution and includes clear, direct messages about how to prevent overdose in the first place and how to rescue a person who is overdosing. So together we have naloxone and overdose prevention education. We call it overdose education and naloxone distribution. That is the one of our key community evidence-based practices. It empowers trainees to respond to overdoses and can be successfully implemented in multiple venues among diverse populations. We knew this before we started the study, and it's why we incorporated it as one of the 3 key evidence-based practices in the ORCCA. So there's a history to naloxone distribution and overdose education. Naloxone as a medication was synthesized for the first time in 1961 and was approved by the FDA to reverse opioid overdose. For the next 30 years, it was largely only used in medical settings or in emergency settings like through ambulances. But in 1996, the Chicago Recovery Alliance, which is a harm reduction organization in Chicago that works with and among people who use drugs, began distributing naloxone directly to their community, beginning the world's first coordinated naloxone distribution program. This effort was really underground and many people thought illegal, but over the next 20 years became really mainstream. It's been the cornerstone of overdose prevention, harm reduction, and people have reported using naloxone to revive friends, peers, partners, bystanders, neighbors, and family members. And now naloxone is a key part of the overdose reduction strategies of most public health and health organizations, including the World Health Organization, the Department of Health and Human Services, the Centers for Disease Control and Prevention, the Substance Abuse Mental Health Services Administration, and the U.S. Food and Drug Administration. So it's very mainstream. It's part of our nation's drug control strategy to reduce the harms of overdose. In Massachusetts, where I'm from, we had early experience with naloxone, and I'm going to tell you that story here. So here's the state of Massachusetts in 2004 to 2006, a time period before fentanyl, but when we were seeing some surging overdoses. And you can see each of the 351 towns shaded based on how many overdose deaths they had over those 3 years. You'll see 2 purple diamonds there in eastern Massachusetts, in Cambridge and Boston. They were the first cities to roll out naloxone distribution programs among people who use drugs in 2006 and 2007. In 2007 and 8, several more towns were added. In 2009, a few more towns. And then you see the yellow circles there. Those are towns that had high numbers of overdoses, but did not implement naloxone distribution programs. And so the differences between the towns with programs and the towns without programs gave us the opportunity to do a quasi-experimental research comparison of communities with and without naloxone. And on the next slide, I'll show you what we found. Okay, so this isn't animating as I would like, but with the first click, you'll see, okay, 0 would be if there was no naloxone coverage, the purple circle there aligns with the purple bar on the right. And that gives you your baseline overdose rate, opioid overdose death rate, where 100% of people that would die if naloxone's not there die. Now you see what happens if you have a low level of naloxone coverage between 1 and 100 kits per 100,000 people. What we observed in Massachusetts was a 27% reduction in the overdose death rate. When you distribute more naloxone, between 100 or more naloxone kits per 100,000 people, you'll see even greater reduction in the opioid overdose death rate. So that's what we observed in the early days of naloxone, and that really formed the basis for convincing public health agencies and harm reduction providers and prescribers and organizations that naloxone could be associated with reductions in overdose death at the community level. Now, there's some concern about and what has developed into some misinformation that I want to address head on. This misinformation fits into the area of what is called risk compensation and moral hazard. There's many examples of this that we've seen in the past that have been debunked. The idea that seatbelt laws make car crashes worse. Of course, we know that seatbelts save lives. That's been shown. There's been arguments that vaccination and condom distributions increase sexually transmitted infections when, of course, we know from the evidence from multiple studies and multiple venues that those things reduce sexually transmitted infections. And then with syringe distribution, there are people who believe that if you distribute syringes, you're going to actually increase HIV infection, when we know over and over again that when in communities where we distribute syringes, HIV infections go down. Well, in each of these cases, you can think of these things being fire extinguishers. And the question that people ask when they're asking, does naloxone increase drug use? It's effectively like asking, does a fire extinguisher cause fires? Well, a fire extinguisher does not cause fires, and naloxone does not increase drug use. This has been looked at in multiple studies, including a meta-analysis. And the results of the meta-analysis were that we found no evidence that take-home naloxone was associated with increased opioid use or overdose. Concerns that take-home naloxone may lead to increased substance use were not supported by data from the reviewed studies. Okay, so let's get to the ORCCA, this menu of evidence-based practices that we provided to the communities involved in the Healing Communities studies. We divided the overdose education and naloxone distribution part of the ORCCA into 3 areas: active OE&D, which increased OE&D or naloxone distribution for high-risk populations and their social networks or venues where high-risk populations were likely to be found. Examples of active OE&D included distributing naloxone in syringe service programs at criminal legal settings and through peer outreach. We also had a part of the menu which was called passive naloxone distribution, which increased naloxone access to individuals referred by other providers or those seeking OE&D on their own, like at a pharmacy, and naloxone for immediate use in overdose hotspots. Examples of this was making naloxone available in retail pharmacies. I mentioned that now it's over the counter, but during the initial part of the study, naloxone was not over the counter, and we had to actively work with pharmacies to make it available to people. Naloxone boxes, which is posting naloxone in areas where overdoses are likely to occur. And then thirdly, naloxone administration increases the capacity for opioid overdose response and rescue by first responders, such as police. So the active OE&D strategies were required. At least one was required by each community. I can tell you that all communities had multiple of these strategies, and then passive OE&D and naloxone administration buckets were optional, although each community, I believe, implemented at least one of these strategies as well. So I want to speak on just one innovation of an example that we're particularly proud of in Massachusetts. There were multiple of these, but this is one example from Holyoke, Massachusetts, where we had a peer stipended program to increase naloxone to people not reached by the current street outreach efforts. Holyoke, Massachusetts is a community that had a robust history actually of treatment for opioid use disorder and with harm reduction. And so that community needed to come up with something innovative to get naloxone to the people that weren't already getting it. And so what they did was they paid people who use drugs to distribute naloxone to their social networks. And that resulted in 702 naloxone kits distributed per month in that community, which was a substantial increase to the naloxone that was already being distributed in that community. And here's a quote from one of the directors of that program, Erica Hensel. 95% of the peer distributors are homeless, and I didn't want to create barriers for them. I also believe that people should be paid cash for their work, and they did not want a gift card where their earned money was limited. There are many other examples from Holyoke and other communities, but that's just a window into one thing that one innovative program. And I look forward to discussing more during the question and answer. I'm going to hand it off to my esteemed colleague, Dr. John Winhusen, who's going to tell us about medication for opioid use disorder. Thank you.
Good afternoon. ORCCA places a heavy emphasis on medication for opioid use disorder, or MOUD for short. This is also known as medication-assisted treatment, or MAT. ORCCA uses the term MOUD since it is more precise both in defining the medical condition being treated, OUD, and in being clear that MOUD is by itself a treatment. There are 3 types of FDA-approved medications for the treatment of OUD. To make sense of the medications, you need to know a little bit about how opioids work. Opioids like heroin and fentanyl work by binding to the mu opioid receptor and activating it. The 3 types of medications represent 3 different strategies to try to block the effects of drugs like heroin and fentanyl. First up is methadone, which has been a medical treatment since 1972. It's an opioid agonist, which means that it binds with the mu opioid receptor and activates it. Methadone's effectiveness as a treatment is through its ability to induce substantial tolerance in the brain opioid system, which serves to block the effects of other opioid agonists like fentanyl and heroin, and it also decreases craving and withdrawal. Methadone for the treatment of OUD is highly regulated and is only provided through licensed opioid treatment programs. Another strategy to block drugs like heroin and fentanyl is to block the mu opioid receptor with a partial agonist, which is buprenorphine, or BUP for short. As a partial agonist, there's a ceiling effect on respiratory depression, which decreases the risk of overdose. BUP binds the mu opioid receptor and partially activates it, which helps to decrease craving and withdrawal, while also blocking other opioids from accessing the receptor. The oral formulation of BUP was FDA approved in 2002, and we also have 2 extended release injectable monthly formulations. BUP can be prescribed by any prescriber. However, some states have requirements around BUP, which, while well-intentioned, can be a significant barrier to access. A third and final strategy is to block the mu opioid receptor with an opioid antagonist, which is naltrexone. Naltrexone does not activate the receptor and so does not offer some of the benefits of methadone and BUP. And it can be difficult to get people started on it since they can't use opioids for 7 to 10 days before starting to take naltrexone, and that can be tricky. The oral formulation was approved in 1994, and the extended release monthly injectable was approved in 2010. Adherence with the oral formulation is a significant problem, and so the extended release formulation is recommended for treatment. For HCS, ORCCA required that a strategy focused on methadone or BUP be implemented. So why that requirement? It's because ORCCA was designed to reduce opioid overdose deaths. There is not yet sufficient evidence that naltrexone reduces opioid overdose deaths, while there is very compelling evidence that both methadone and BUP do. There are a number of studies that have found this relationship, but given time constraints, I'm sharing the results from a systematic review and meta-analysis conducted by Santo and colleagues. Relative to times when individuals were not in methadone or BUP treatment, being in treatment was associated with a 53% decrease in all-cause mortality and significant decreases in suicide, cancer, drug-related, alcohol-related, and cardiovascular-related deaths, with the highest decrease being for drug-related deaths. In addition, there was a dramatic decrease in mortality rates for people receiving methadone or BUP treatment during incarceration and post-release, with decreased mortality risks of 94% and 91% respectively. The next two slides provide a more global perspective. This graphic from Baumgartner and colleagues shows drug-related deaths per million for 13 countries using data from 2020 or the most recent data available. As you can see, we, the US, have the highest rate of drug-related deaths. We know that methadone and bupe treatment saves lives, and most of the research to develop and test these medications has been done by us in the US. So how do you think we compare to the other 12 countries on the percentage of people with OUD receiving these medications? Next slide. We are dead last in the percentage of people with OUD receiving treatments that we know save lives. It kills me to think of how many lives we've lost because we are not effectively engaging people in MOUD treatment. There are a number of barriers, but a huge one is stigma and misconceptions about MOUD. So I want to take a moment to address what I think is the most common and damaging misconception, which is that methadone and bupe treatments are just replacing one drug with another. I can understand why people have this impression, particularly for methadone, which is an opioid agonist. But there are critical differences between methadone and bupe and, say, heroin and illicit fentanyl, with half-life being an important factor. Half-life is used to estimate how long it takes a drug to leave your body. As you can see, heroin has an extremely short half-life, with an estimated average of 3 minutes. Fentanyl's is longer, but still much shorter compared to the average half-life of 24 hours for methadone and 38 hours for bupe. The difference in half-life is related to its different effects. Both heroin and fentanyl produce euphoria and encourage compulsive use since the drug leaves the body relatively quickly. In contrast, once a steady state is achieved, euphoria is not experienced with methadone or bupe. Because they both stay bound at the mu opioid receptor, they decrease craving and withdrawal, and they both work to block the effects of opioids like heroin and fentanyl. In a nutshell, drugs like heroin and fentanyl encourage compulsive use and put people at a heightened risk for dying, while methadone and bupe are safe and effective treatments that give individuals a chance to pursue healthy and productive lives. This includes resuming their roles in society, including both family and work roles. So no, we are not just replacing one drug with another. Methadone and bupe have very different pharmacology that helps to stabilize the brain and produce positive public health outcomes. Treatment saves lives, heroin and fentanyl take them. I also want to address a common objection to oral bupe, which is the potential for diversion. Diversion definitely happens. Research suggests that for individuals with OUD, they mostly use diverted bupe to keep themselves from going into opioid withdrawal. Remember that bupe is a partial agonist, so it does not fully activate the mu opioid receptor, which means that for someone with OUD, it is not their go-to for getting high. Adams and colleagues recently conducted simulations to estimate the potential impact of bupe diversion on opioid overdose deaths. They considered 3 scenarios. The first was the current status quo, for which they estimated that 50% of individuals prescribed bupe divert at least 1 dose per week, and that 10% of those with OUD use diverted bupe at least once a week. Scenario number 2, no bupe diversion. And the third scenario was increased diversion. For that, they estimated that 95% of those prescribed bupe divert at least 1 dose a week, and 50% of those with OUD use diverted bupe at least once a week. The graph shows the comparison of the status quo, no diversion, and increased diversion at the top, and then the results comparing the status quo with increased diversion using 4 different sets of assumptions. In all of the scenarios, increased diversion had similar or fewer overdose deaths compared to a scenario with no diversion or the status quo. These findings support low to no barrier access to bupe treatment, even if this leads to increased diversion. So now that you understand the importance of MOUD, let's discuss ORCCA's approach to increasing MOUD engagement, which includes 3 sets of strategies. The first is to expand MOUD treatment availability. This is a no-brainer. People won't be engaged in MOUD treatment if there is no treatment to be had. Availability of MOUD varies greatly among communities. In HCS, we have communities with a great density of MOUD treatment options, whereas in some communities, there was no MOUD, not even extended release naltrexone. So you need to assess the treatment landscape in your community. ORCCA outlines potential venues, strategies, and resources for MOUD expansion. 2 sample strategies implemented by HCS communities included implementing BUP treatment in jail settings, and establishing opioid treatment programs. Implementing methadone and BUP during incarceration and ensuring linkage to ongoing care post-release is likely among the most impactful strategies for decreasing opioid-related mortality. I know that New York State has mandated that all 3 medications be offered to incarcerated individuals with OUD. In my opinion, all states should follow suit. In any case, several HCS communities successfully implemented de novo BUP treatment in their county jails, so it is definitely doable. One potential resource to get you started is listed here from the National Sheriff's Association and National Commission on Correctional Healthcare. The other example I've listed, establishing an OTP, is probably the most challenging strategy to implement, but several of our HCS communities were successful. If your community does not have a licensed OTP, you should consider making this a priority. The resource listed here, the Federal Guidelines for Opioid Treatment Programs, provides an overview of what's involved. The second global ORCCA strategy for increasing MOUD treatment engagement is to link individuals with OUD to MOUD, because unlike the field of dreams, if you build it, they won't necessarily come. Active linkage is needed. ORCCA includes 2 approaches. One approach is to improve linkage to MOUD from venues where people with OUD may be encountered. For example, you can attempt to connect people coming to syringe service programs to MOUD treatment, say by having a treatment navigator set up an appointment for them and even taking them to the appointment. The second approach is to initiate people with OUD on MOUD and then link them to ongoing MOUD treatment. This is the recommended approach because receiving the medication allows them to focus on following through with treatment as opposed to focusing on obtaining illicit opioids in order to avoid going into opioid withdrawal. 2 sample strategies implemented by HCS communities included implementing ED-initiated BUP with linkage to ongoing BUP treatment and establishing bridge clinics. Emergency department visits related to OUD are fairly common, and of course there are providers on hand, so the ED is a good place to initiate individuals with OUD on BUP and to link them to ongoing treatment. A number of HCS communities successfully implemented this strategy, so again, it is very doable. You can find more information about the approach in the sample resource listed here. A number of HCS communities were also successful in establishing bridge clinics. There are different bridge clinic models, which are nicely described in a paper by Taylor and colleagues. What they have in common is that they provide low barrier and relatively immediate access to MOUD, typically BUP, but some also offer access to methadone, and they continue to provide treatment until the patient can access long-term MOUD treatment. The final global ORCCA strategy for increasing MOUD engagement is to improve treatment engagement and retention. MOUD treatment retention is strongly associated with decreased mortality, with mortality risk increasing dramatically after discontinuing MOUD. The optimal length of MOUD treatment has not been determined, but the National Quality Forum, which is the gold standard for healthcare outcomes, has endorsed MOUD retention through 6 months as a critical outcome. Different studies provide different estimates, but some meta-analyses suggest that 50% or more of patients drop out of MOUD treatment by 6 months. So we definitely need to do better with retention. The ORCCA strategies implemented in HCS largely focused on removing barriers to treatment, which is the topic of our next speaker, Dr. Hunt. So I will hand you off to him after I show you my references. Well, they flew by. Dr. Hunt, please take it away. Thank you.
Thank you, John. And thank you all for joining today and for your shared commitment to overdose prevention. We are really privileged today to share with you some of the experiences we've had during the Healing Community Study. And Alex said, working with this group of investigators and more importantly, the communities in which we work, the 67 communities and those people with lived experience has been a great honor. Some of the lessons learned from this are represented in the ORCCA approach, and we're going to highlight today the concept that we've learned, and of course we all know, is that you can build it, but they may not always come. Because there is treatment does not mean people will be engaged or that they will be successfully retained. So the element we want to highlight today is addressing barriers to engagement in treatment and then also retaining people in treatment. Again, one of the concepts, the social determinants or social drivers of health, has been widely researched and has taken a great being highlighted in our work here today and ongoing and future research, because things like, as you see, housing, homelessness, impacting the way that people are engaged in care, employment opportunities, and impacting the retention in care as well. Education levels and income stability, of course, impacting whether one can feel they can stay in care or will be engaged in care or motivated to be in care. And of course, retention, so that if someone does not have a roof over their head with shelter, how can I think about treatment or stay in treatment? And I like to think often, one of our, Dr. Chandler, I heard her say once that sleep is sometimes the best treatment for drug addiction. And on the next slide, you'll see another framework which really does highlight other aspects of resources, both internal and external, that can be engaged to support someone in their journey toward recovery. The Recovery Capital Framework, which highlights the range of resources one may have, both internal, whether it be motivation, just the coping skills, the confidence that comes in self-efficacy, one's belief that they can do it or they can bounce back from adversity. The external resources, again, we are not all given the same resources from the beginning, but those family and social network support, the group support, again, as I mentioned, housing, but even access to emergency rooms and primary care have been seen in an index that we developed as part of the Healing Community Study to show that fatalities were associated directly with the access to an emergency room, primary care, insurance, and housing. Again, this particular quote, a person who uses drugs saying, housing is the biggest health risk of anyone who uses drugs, and it affects everything in their lives. So as we think about this and you're developing your strategies, and you take the ORCCA menu that we're providing today, and you begin to tailor your strategies to the local context in which you're working, making sure you're addressing these particular barriers, identifying and listening to the people who use drugs themselves about what they think is the best avenue of engagement and retention, and how we can address those along the way. I'll give you some examples from our states and our implementation in just a moment to kind of bring the strategies alive. On the next slide, again, a very important concept is the disparities that exist among race and ethnicity when it comes to the overdose risk and death. As you see in this particular data, we continue to see the escalation of fatalities among those people of color, the non-Hispanic Native American, non-Hispanic Black, 7 times greater. Black men are 7 times greater than older white men of experiencing overdose deaths. And so our strategies must always be thinking about what are the barriers to engagement, what are communities of color saying about their needs and gaps of resources, really engaging them and elevating their voices in the community, as we have done specifically in the Communities That Heal intervention. On the next slide, you'll see some of the demonstration of that commitment in this particular strategy, improving the way people can access care and stay in care equitably. So literally in the intervention, we talk about ways, and this is always an ongoing process, showing the commitment to reaching and working toward equitable outcomes, those who have been systematically underserved or disproportionately affected by fatal overdose, whether it be structural racism or other disproportionate ways that people have distributed access to resources. These have to be elevated as you think about your strategies. Again, it comes down to very practically, the access to pharmacies where medications that John just talked about are available in pharmacies, prioritizing the inclusion of marginalized communities within our coalitions, making sure their voices are heard, that they are represented, and that service providers from those communities also look like the communities that they're serving. And so we have lots of work to be done when it comes to training those providers and making sure we're incentivizing people coming into the profession to serve those communities. The strong focus on diverse neighborhoods and tailoring the approaches among Black and Latinx communities, especially to address the sharp increases in overdose deaths. Again, we need to be looking at things like stimulant use, of course, the synthetic opioids, cocaine use, and the ways those are impacting the current overdose epidemic. And I see someone in the chat saying, are we working with those populations, or do we have strategies to address those risks? And again, a data-driven approach, right? We're not just kind of throwing things against the wall to see if they work, but we're using these evidence-based practices. We're tailoring them to the point that we're directing them into the neighborhoods and locations where people are at the highest risk for overdose. So we use that data to inform our strategies. We make sure we're collecting demographic data to see, are we reaching those people that we are trying to serve? You'll see the whole menu of options that I hope that you take advantage of the practice guide. So you see all the opportunities to address barriers when it comes to promoting both menu 1 and 2, as we've discussed today, by addressing things like childcare, shelter, access to primary care, housing, and then recovery support, especially driven by peer supports. We know those are so effective, making sure that peers are funded well, that their voices are heard and listened to, and that they're supported in their work and valued throughout the process. So in the next slide, I'm going to give you just a few examples from our communities that maybe can bring it alive. And then we look forward to hearing your questions about some of the strategies we have been implementing. This particular approach is a combination of strategy. The ORCCA, the ORCCA group, Opioid Response as County Law Enforcement, is in one county partnered with Family Services, also with the Department of the Social Services and Mental Hygiene, as well as a local motel to provide vouchers for those who were seeking treatment. So prior to getting into treatment, we used overnight vouchers for those who needed emergency care, and we also provided vouchers once leaving treatment, so making sure there were no gaps in housing. Additionally, we funded an urgent care integrated care model with mental health and substance use treatment available 24/7 so that people would have access that throughout their journey to recovery. On the next slide, you'll see an example of transportation needs provided here in Kentucky, in which 400,000 miles where a peer driver was taking those to treatment. So the model includes the ability for that peer recovery coach to talk to someone on their way to their medication for opioid use disorder treatment. And also bus passes were used, fuel cards were used, and also Uber rides in this particular strategy. So addressing the gaps in transportation, especially in those rural areas outside of urban areas that are certainly in need of transportation and don't have mass and public transportation services. Thank you to the Voices of Hope who led this strategy. On the next slide, you'll see in Ohio, in New York, addressing mobile services in 2 different ways, in which the Bridgeback service combined an outpatient service, it combined telemedicine, peer recovery support, it combined the overdose education with an assessment through telepractice and screening, and then a partnership with a pharmacy in which referrals were made for medication. So this comprehensive approach could be taken into neighborhoods, for example, where there were deserts of resources, and certainly where there were no methadone programs specifically, or possibly no buprenorphine providers. Another expansion in New York has been the commitment to mobile methadone, in which $6 million has been allocated for 11 of these units to provide mobile methadone. It has begun by servicing. One that John mentioned was jails, where people who have opioid use disorder, where methadone is the medication of preference, must be provided that methadone. And more broadly, these services can be brought into rural areas, especially where some counties have no methadone programs. So this is a brand new program that is up and running. Another 6 mobile units will be coming out in the next 2 months. An example around basic childcare. And this, again, in Ohio is an example of a cross-sector collaboration between the YMCA, which provided the services for childcare. The Rhodes College Early Learning Services provide the activities specifically, and the Mental Health and Recovery Services Board, who helped make these referrals for those people, those parents who were going to treatment, but where childcare was getting in the way of them actually seeking that care. So again, reducing the barriers, increasing the access to resources that are needed to get into care and then to stay into care. And it takes a community. It takes a collaboration between the partners, and it takes also listening to those people who are seeking the services to design them so that they would like to seek that services and like to stay in that service. So I'm going to turn it over again to finally our last menu to Dr. Trish Freeman, who's going to talk about our menu 3, which is the opioid prescribing, dispensing, and disposal.
Thank you, Tim. It's a pleasure to be here this afternoon to provide an overview of ORCCA Menu 3, which, as Dr. Chandler said, is focused on increasing prescription opioid safety. It's important to acknowledge that prescription opioids are not currently the main cause of opioid overdose deaths in our communities. And strategies in Menu 3 are really unlikely to have a substantial immediate impact on reducing opioid overdose deaths. But however, when we talk about Menu 3, it's really focused on what we often call primary prevention, right? The things we do to protect the population of people who don't yet have a medical condition. For opioid overdoses, primary prevention is about preventing opioid use disorder by limiting initial opioid exposures and about making sure that patients that are taking prescribed opioids are as safe as possible. You can see that, the risks related to prescription opioids often stem from misuse, which is when a prescription medication is taken in a way that isn't directed by a prescriber. In this SAMHSA survey, misuse includes things like taking your own prescription more often or for longer than the prescription indicates, as well as taking a medication that was not prescribed to you. As you can see, misuse is pretty common in the United States, with 8.5 million people reporting misuse of prescription pain relievers in 2022. 5.6 million people had a prescription pain reliever use disorder, which puts them at even greater risk for opioid overdose or other opioid-related harms. Among people who misuse pain relievers, about 45%, which, really is about half, obtain them from a friend or relative, and most often for free. And what these stats emphasize then is really the importance of appropriate prescribing, patient education, and prompt opioid disposal to limit prescription opioid availability in a community and reduce risks related to opioid misuse. In the first wave of the opioid overdose crisis, prescription opioids were primarily responsible. But since that time, we've had numerous policy changes that have included things like increasing use and mandating the use of prescription drug monitoring programs, release of the guideline from the CDC to really help inform, prescribing decisions. States have implemented policies, for example, to, put limits on the day's supply of acute opioid prescriptions. And all of these, this emphasis and all of these policy changes has really, resulted in a significant decline in the number of opioid prescriptions dispensed in the United States. And this slide just shows a couple of maps on the left from 2019 and on the right, 2022. And what you can see is an overall decline in the US opioid dispensing rates per 100 people, although you can still see a nice pocket here in some of our southern states, including Kentucky, where I'm from, where dispensing rates continue to remain higher, quite a bit higher, frankly, than the national average. And these maps are available on the CDC's website. And in fact, you can look at maps that go all the way back, to like 2006 or so, I think. So very informative. So we know we've decreased opioid dispensing rates. And, in response, as I said, some of this has been due to these policy changes. The first CDC guideline was released in 2016, and the most recent guideline was updated and came out in 2022, which provided 12 recommendations for prescribing opioids for pain. These are voluntary guidances to really help prescribers make decisions around when to initiate opioids, what opioids and at what doses are the safest to initiate, how long for different conditions should opioids be used, and then really how do we individually assess our patients, assess the risk, and address potential harms with those who might be needed to be prescribed opioids. So some of the features that we know from various studies in the literature, and these are summarized to great detail in the CDC guideline, things that we know that increase risk, might increase risk in a given patient are shown here. Things such as high doses, greater than 50, what we call morphine milligram equivalents, using prescription drugs in combination that also have central nervous system depressant effects. So things like benzodiazepines or gabapentinoid medications. And on the right side, things within an individual patient, how old are they? Do they have sleep apnea or other sleep disorder breathing conditions? Do they have concurrent mental health conditions or maybe a history of substance use disorder and overdose? So all of these things together really make us recognize that the key to prescription opioid safety is really focusing in on those risks and benefits at the individual patient care level. And so I think it's really, really important that we understand the vast majority of patients who use opioids do not develop opioid use disorder or experience overdose. I mean, opioids are an important tool in our medical toolbox for treating pain. And when we think about, as a healthcare provider and as a pharmacist, I'm personally a pharmacist, we're always tasked with ensuring that the medication choices we make consider patient factors, the medical situation, the potential risks and benefits related to a given medication. And because opioids carry some rare but very serious risks, we must also ensure we are implementing risk mitigation measures like monitoring patients for opioid use disorder, co-prescribing in the naloxone, and encouraging appropriate disposal for leftover medication, and so on. So I want to turn our attention just a minute to disposal and why disposal is so important. Multiple studies have shown that many of the doses of prescribed opioids go unused. And these are just 3 examples that I have on this slide. And I think it's really, it's sort of astounding to think that following orthopedic surgery, 94% of patients, when they come back to the clinic, report having unused opioids from the prescription that they received. In just a general orthopedic clinic, over 1/3 of the patients that were in that clinic and responded to this survey reported unused opioids in the home. We need to really understand that unused opioids in the home increases risk. One study estimated that the availability of opioids from a household member increased the odds of opioid-related overdose death by 60%. And among high school seniors, 37% of past year non-medical users of prescription opioids obtain these medications from leftover doses of opioid prescriptions from physicians or dentists. And on the right, I showed this earlier in a different format, but when you look at these data more broadly, from the National Survey on Drug Use and Health, we estimate that almost 1/2 of those reporting non-medical use of opioids were obtained from a friend or relative. And so with these data in mind, the ORCCA Menu 3 was focused on increasing the safety of prescription opioid use. And so our communities were able to select strategies from safer opioid prescribing and dispensing practices, really focused on both acute pain, chronic pain in varied healthcare settings within their communities, safer opioid dispensing at the pharmacy level, and then safer opioid disposal practices, really including things like installing those prescription drug take-back boxes in pharmacies, implementing mail-back programs, or some of those home disposal pouches and things that individuals can use at their home and dispose of in the trash. The communities were required to choose at least one strategy from the safer opioid prescribing and dispensing practices, and then the safer opioid disposal practices were optional. Almost all of our communities still selected multiple strategies, as has been discussed previously, in this menu. As Dr. Chandler showed, I think 203 strategies total across our 67 communities. So I'm going to just provide a couple of examples of the strategies that were used. So for safer opioid prescribing, examples of strategies that our communities use were really mainly focused on providing education and technical assistance to prescribers. Things like webinars, continuing medical education, technical assistance, really related to policies and procedure development, alerts in the EMR to really help people, understand that maybe you should choose a different opioid or that opioid dose may be too high. This is an example from Massachusetts highlighted here from their consult service, where they actually provided, education and technical assistance to prescribers who had questions about a particular case. And you can see a continuing education flyer there as well. As pharmacists, we were very interested in Kentucky and really, working with our communities with their pharmacies. And so our communities were very excited to choose, all of them choose safer opioid dispensing as a strategy. And so we deployed a team of academic detailing pharmacists in our communities to work with the communities and the community pharmacies really to help assist them in understanding current opioid evidence-based practices. We used these academic detailing. We went to the pharmacies and did visits. And these are our did you know cards, where we met with the pharmacists in the communities to help them understand regulatory changes. Things like, the DEA's final rule that it's okay to partial fill Schedule II opioid prescriptions, focusing in on the risks of tapering or discontinuing opioids too quickly. And so these were very well received in our communities. Here's another example of a webinar, experience and evidence understanding opioid related best practices, that was in Massachusetts. And then finally, it was optional, but some of our communities chose the optional strategy of safe disposal. And these strategies, as I mentioned, included the drop box installation. You see a picture here of the take back box, those home disposal kits. And then a lot of our communities, were very keen on just raising awareness of the importance of disposal and making sure that people understood that there were locations within their communities where drugs could be disposed, and encourage people to participate in the National Drug Take Back Days. So I'm going to stop there, and I'm going to turn it back over to Jess, who is now going to talk a little bit about the ORCCA resources and moderate our Q&A.
Thanks, Dr. Freeman. Thank you to all of our speakers. Such amazing information compressed into really useful presentations and lots of data and examples for all of our participants to be able to use in their own work and in their communities. We wanted to also just highlight, and there's links here in the chat as well, a number of resources that have been created around ORCCA and the menus, really digging in on implementation support in the toolkit that SAMHSA put together. There's a policymaker's guide that provides sort of an overview of the key recommendations and strategies in ORCCA. We also have social media content and campaigns. There's an infographic that you can use. We will have the recording from today's webinar and the slides available both to all of our participants today, anyone who registered, and we'll have it up on the Addiction Policy Forum website. And if there's other content or resources that would be helpful for you to share what we know works from the ORCCA framework, and to make sure you disseminate that to policymakers and other decision makers in your community, just let us know and we'll get to working on it.